Massachusetts office and the regional lead for the quality payment program eligible clinicians work that we do. So first things first, this is a very exciting time. The CMS Quality Payment Program Year 2 proposed rule was released last night at about 4:30. So the team here has been busily reviewing all of the changes that have been proposed, and we'd like to share some of those with you now. As a reminder, all of these are proposed, so they might take effect for next year, the 2018 program year, or they might not. Comment period is open until August 18th of this year. So if you have any comments that you'd like to submit to CMS regarding the changes, please make sure to do that. So you can also access the proposed rule via this link. That's right to the Federal Register to review the document. It's over 1,000 pages, 1,058 pages, so there's lots of reading. So what are we seeing? First, performance threshold has been increased to 15 points. Currently, in order to avoid a payment penalty, the performance threshold is only 3 points. So there is an expected increase in performance. Clinicians can earn bonus points through using different ways of caring for more complex patients. CMS will be adding an adjustment of up to 3 points to your final score using an average hierarchical conditions category, so the Hcc Risk Scoring. This is a tool that looks at the 79 HCC scores, and it identifies individuals with serious and chronic illnesses and assigns a risk factor score to the person based on the combination of their health conditions, demographic area, and a couple other factors. This score is often used in ACO payment structuring, so if you're part of an ACO, you might already be familiar with it. Another big change proposed with the the proposed rule is that 2015 certified electronic health record technology has now been made mandatory. Not mandatory. It was mandatory. It will now be an option. If you do use it exclusively, you can earn bonus points. Clinicians and practitioners are also allowed to continue using 2014 certified EHRs, and that would just be the standard measures that they're currently reporting on now. In terms of evaluating the mixed performance improvement categories, quality will also be able to earn some additional bonus points. This is based on higher improvements in performance. So anyone who reports for the 2017 performance year, if they can demonstrate that they have improved their performance, they can earn up to an additional 10 performance points. So some options if you're looking to continually increase your performance. Another proposed change is that currently all of the performance categories, clinicians are restricted to one submission methodology per performance category. You can select different ones between the different categories, but you have to have one submission method per category. CMS is considering opening that up so you can actually submit via multiple methods within one category. Another big change for the smaller groups and rural clinicians is CMS will be offering virtual groups as a participation option. What this includes is groups of 10 or fewer clinicians, so a solo practitioner and a group or whatever the case is, mix and match, can come together and receive the same benefits as a group that maybe is housed within the same practice walls without actually having to be within the same geographic area. Solo practitioners and other groups will need to choose that option for participation prior to the 2018 performance year. So once this is all finalized, again, hopefully sometime in October, late October of this year, if a clinician or group decides they want to become part of a virtual group, they'll need to denote that for the 2018 performance year. A change for hospital-based clinicians is that there's an option to use a facility-based measurement, which would take hospital total performance scores and move that into the quality and cost performance category. So that's looking at clinicians who fall under the hospital and utilize the value-based purchasing model through the hospital to equate for their quality and cost scores. So they're not doing additional reporting. They get some of the benefit of being a hospital-based clinician. Next, I'm going to talk a little about the changes that are coming with the various performance categories. Starting with quality, the performance score will remain at 60% of the MIPS total score for 2018. However, there is a mention that the reporting period will go up to 12 months. At the current time, clinicians have the flexibility to report a single measure for one single instance for one patient, or 90 days or a full year, or any combination in between that. It does look like the requirement may be as long as the full calendar year, 12 months. Measures that do not meet data completeness, which means that they don't meet the criteria for a number of cases, instead of getting 3 points, which they currently get in this transition year, there's talk that they'll get only a single point. So if you're limited in the amount of patient data that you could submit for quality measures, I would encourage you to contact the QIN QIO for assistance, because those measures could very well only earn you a single point. And if you're reporting on several measures, you're really not scoring very highly in the quality category. For small and rural practices, however, the data completeness will remain at 3 points. CMS is also proposing to use a cap selected topped-out measures. As you might be aware, topped-out measures in future years of the quality payment program can also only earn you 3 points. So that is something to keep an eye on if you're considering reporting on those topped-out measures. Cost, currently at 0% of the MIPS total score. CMS is proposing to keep costs at 0% for the 2018 performance year. However, it would quickly jump to 30% potentially in the third performance year, 2019. So it's very important for clinicians, if this does get passed in the final rule, to be aware of their utilization and costs going forward, because this will become quite a bit of the final score in the future years. There's also a mention that this would come from a 12-month reporting period. Again, if it's 0%, that won't matter quite as much, but it's important to know where you stand currently. CMS is also considering using Medicare spending per beneficiary and total per capita cost measures in calculating the score versus the previous discussion of the measures from the QRUR report that looked at encounter-based and procedural-based encounters. Improvement activities, again, this will remain at 15% of the total MIPS score. The reporting period remains at least 90 days. There is talk of adding additional improvement activities and changing some of the current improvement activities. No word on exactly what those will be, but stay informed on that. CMS is also looking at adding a new improvement activity around appropriate use criteria. This is specifically looking at diagnostic imaging. And in diagnostic imaging, it's making sure that whatever those advanced diagnostic imaging services that are ordered are being ordered appropriately. There's also consideration for making CPC Plus, which is Comprehensive Primary Care Plus models, alternative payment models, into a recognized patient-centered medical home, which would earn those practices full credit towards the improvement activities category. And changes to how that's currently structured for PCMH practices. CMS is proposing that there's a threshold of at least 50% of the number of practices within a specific PIN looking to use PCMH as an approved improvement activity in order to get credit for that improvement activity. Currently, as long as one clinician within the PIN is certified as PCMH, all the clinicians can take credit. Now it would have to be at least 50% in order to take full credit. For advancing care information, this is also remaining at 25% of the total MIPS score. Reporting period is, again, still at least 90 days. There will be, or at least there's talk that there will be an exclusion for the health information exchange measure. Individuals that are familiar with previous meaningful use methodologies know that there was an exclusion. If you had fewer than 100 transitions of care, you did not have to submit the summary of care measure. As MIPS currently stands, there is not the same exclusion. So this could change things a little for those clinicians that have fewer than 100 transitions. In place of the immunization reporting requirement, CMS is considering allowing eligible clinicians to earn 5 points for each reporting to a public health registry or to a clinical data registry with a max of 10%. So you lose a few points potentially if you wanted to report the immunization registry as one of your performance measures under the advancing care information category, because that currently would get you 10%, and reporting to a clinical data or public health registry would also get you 5%. You're now capped at 10 if you can't report to the immunization registry, but some additional options if you're interested in that way. Due to the nature of various electronic health records technology vendors and the struggle that they have had over the years to get up to speed with the various requirements, CMS is considering a decertification exemption. Under this, the eligible clinicians whose EHR was potentially decertified would be retroactively affected with this performance exclusion, and this actually goes back to this current reporting period of 2017. So as we know, EHR technologies are struggling a bit to get all the requirements in place, so this would help if for whatever reason your EHR was decertified. There's also a change to the hardship exemption. The deadline currently is at October 1st of 2017. For this current year and for future years, the exemption potentially will be extended to December 31st. Now, some of you might be scratching your head a little because at the beginning of this presentation I said the final rule will likely be released mid to end of October. Obviously, if it's released mid to end of October, you won't know that the exemption has been extended to December 31st prior to the requirement of the exemption being submitted October 1st. So plan to report the exemption if you're going that route October 1st of this year. If for whatever reason something changes and you need to report it, you might get flexibility to December 31st. The final element of advancing care information that has changed is that there's some additional flexibility in reweighting the category to 0 and increasing quality to 85%, so taking the 25% from the advancing care information category. This follows the 21st Century CARES Act. It was actually enacted shortly after the final rule for the quality payment program was released in October of 2016. This came out in December. And what it really focuses on primarily, this is for the 21st Century CARES Act, focuses on behavioral health and substance abuse funding, medical research, FDA drug approval processes, and healthcare access. Now, a component within that is allowing for flexibility where clinicians in ambulatory surgical centers would be able to have their ACI score reweighted to 0. Again, that would mean their quality score would jump to 85%, improvement activities would remain at 15. This also allows for a significant ACI hardship for hospital-based clinicians. Those of you in small practices, there's quite a bit of changes coming down the road for you, which hopefully will help in reducing some of the burden for small practices and those in rural and health professional shortage areas. The low volume threshold potentially will be increasing. So currently the low volume threshold is $30,000 in Medicare Part B claims. With the proposed rule, it could potentially go up to $90,000 in Medicare Part B claims. And also currently, clinicians have to see at least 100 Medicare beneficiaries annually. This new proposed rule would increase that to 200 Medicare beneficiaries annually. So some increases there, which potentially would exclude some of those smaller and rural practices. Additionally, there's some new exemptions for the advancing care information category for those small practices. This would, as I mentioned before, reweight the ACI category to 0 and increase quality to 85%. There's also some possible changes to the final score of MIPS for these small practices. There is talk that they could have 5 points added to their final score as long as the eligible clinician or group submits for at least one performance category. So they need to submit at least enough data to satisfy one of the performance category requirements, and they could get an additional 5 points to their final score. And as I mentioned before, small practices will continue to receive 3 points for measures, even if they don't meet the data completeness requirements. Again, this is all proposed rule. Nothing has been finalized yet, so this all might change. The last section I'm going to get into before jumping to our frequently asked questions is in regards to alternative payment models. Couple changes here, nothing too major. For MIPS APMs, so those are APMs that don't share the upside downside risk, they only take on upside cost sharing, and also advanced APMs that don't meet the qualifying participant threshold, they would have an additional, a fourth snapshot date added, which would go until December 31st, and this would be used in determining those clinicians that are part of either a MIPS APM or an advanced APM that could use the MIPS scoring standard. Performance category weights for these categories, so 50% for quality, 30 for advancing care information, and 20 for improvement activities would all remain the same. Excuse me. For advanced APMs, there's an adjustment to the nominal risk factor rate, which is across a couple of the different models. I won't get into that further just because it really depends on the model that you're in, but there is some adjustments there, and I would highly recommend if you're in one of those models and are thinking about that rate to go check out the final or the proposed rule. There's also an addition to the Medicare qualifying participant determination period. So currently it's January 1st to August 31st. For Medicare qualifying participant determination, that will remain the same. However, in the next performance year for 2018, there is talk that there will be creation of an all-payer qualifying participant determination period, which would be January 1st to June 30th. So a little change there. It depends on if you're participating in other all-payer alternative payment models, so keep that in mind as well. As I mentioned, that qualifying determination for the all-payer combination method would be at the eligible clinician level only. For the Medicare qualifying participant determination, that's at the APM aggregate. The whole entity would get that determination. For the all-payer model, it's at the clinician only. Since I just covered a ton of material, I'd like to open it up for questions. So as Olivia mentioned, if you press *6, your line will be open.
#6.
#6, sorry.
No, it's okay. I'll put it in chat too.
All right, so it doesn't look like anybody has questions on the proposed rule, probably trying to digest all of the changes. So proposed rule aside, we've heard a couple things recently from various APMs and MIPS eligible clinicians that we just wanted to share with you, and then open the lines up for any further questions that you might have. So in terms of MIPS eligible clinicians, we've heard a lot about using the CMS web interface, previously known as the G-Pro web interface, for reporting. And if you used this last year for PQRS, you're probably familiar with it. But clinicians are wondering, if you don't want to use this as your reporting method for this year, what do you need to do? So this is actually a really important question, very timely. If you have previously reported using the CMS web interface, you are kind of automatically grandfathered in. Your registration was carried over to this current reporting year. Excuse me. And if you're not using that method for reporting this year, you'll need to actually go into the CMS portal, which we can provide you the link for, and you'll need to cancel your registration. And that needs to be canceled by no later than June 30th. So next Friday, you would need to have that registration canceled. If you don't cancel it, CMS will be expecting you to submit your data via the CMS web interface for 2017. So pretty important. We have some questions at the CMS on whether or not you would get penalized if you said you were reporting the web interface and decided not to after the fact. But because they're requiring you to cancel your registration, I would expect there probably is some penalty in there. So plan to cancel it if you're not using it, or register if you decide you want to use it. Again, if you didn't use it previously, you would need to register. That's also by June 30th, which is next Friday, and we can send you all of the information on that. For alternative payment models, we've heard several questions about members of the ACO that they're talking about and how they get included in their participant list. So some really important things to consider when talking about alternative payment models, whether it's a MIPS APM or an advanced APM, is that participant list. So the participant list is what gets sent to CMS saying that all of these PINs, so tax ID numbers of the various practices, and all of the associated NPIs, which are the national provider IDs of the clinicians under the PINs, are considered to be participants of that ACO. CMS looks at this list on 3 snapshot dates. The first being March 30th, or 31st, sorry, which obviously already passed. The next is coming right up, June 30th, which is next Friday, as I mentioned. And the final is August 31st. If for any reason a clinician was maybe previously part of an ACO or APM and decides to leave prior to that final August 31st date, they are now eligible for reporting MIPS on their own or as a group, however they decide they want to report. If a clinician decides to join an ACO but doesn't join until after that August 31st snapshot date, they are also still eligible to report MIPS and would need to report MIPS on their own. This is key, especially in organizations that have a lot of clinicians moving around within their ACO or APM, maybe joining late in the year or leaving later in the year, whatever the case might be. It is a bit of a record-keeping nightmare to know where everyone stands. We did have an APM express great concern over the level of complexity of reporting to both the APM structure and the MIPS structure for these various clinicians. So I would say keep a close handle on who is on your participant list and where they are going to need to be reporting if for any reason they leave after that August 31st date. The second, kind of in line with that, is we had several questions about groups of providers who are part of an ACO but only considered to be preferred status. So they're not actually part of the participant list. And do they actually get to reap the rewards of participating in the APM if they're only in that preferred status? So the answer to that is no. Again, CMS evaluates APMs and participation based on the participation list. The preferred status does not get them on the participation list necessarily. So if they're preferred, oftentimes they're considered, again, a preferred partner with the ACO. So maybe it's a specialist that the ACO or APM sends any of their cardiac patients to or surgical patients to, whatever the case might be. But they're not actually considered to be part of the ACO's participation list. As such, those clinicians, much like the clinicians that either leave an ACO or join an ACO after the August 31st snapshot date, are eligible to report MIPS and would need to report the MIPS track for 2017. Now, if they're in a solo practice, they can report obviously as an individual. If they're in a group practice, they can report as an individual or as a group, whatever suits their needs, and we are more than happy to help them if they have questions with that. That covers the main FAQs that I wanted to share with anyone. I'll open up the line. Again, it's Chaplain 6. If you want to open your line and ask a question, you can also type it into chat, I believe.
Yes.
I see someone typing, so I'll give them a moment to type their question. Here's some resources as well. This is the website to the New England QIN QIO's macro webpage. We have some great resources there. You can also ask a question if you don't want to ask it right now or you're not sure. Feel free to send us a question directly through that ask a question link. And then finally, I just want to highlight if you're a Massachusetts practitioner, we have a wonderful free personalized technical assistance event going on with the Massachusetts Medical Society. We actually have 2 dates running. One is July 11th, the other is July 27th. Both will be held at the Massachusetts Medical Society headquarters in Waltham, and they're from 5:30 to 8 p.m. We will have dinner served, and you will have a nice working session where hopefully you can get all of your additional questions answered. Okay, let's see. So Pam, you asked if a provider MPI was left off the participation list, but their PIN is part of the list that was sent to the participant section, does the MPI that was left off have to report MIPS? So yes, it's important to make sure that all of the PINs and MPIs line up, because if you think of it this way, so a PIN could be a multi-specialty group, let's say of 5 clinicians. One is internal med, one is cardiology, one is surgical specialty, one is psychiatry, and one is, I don't know, whatever else. Only 2 of those clinicians potentially are participating in the ACO, whereas the rest are specialists that are potentially not participating. While that PIN and those 2 individuals might be participating, the other 3 would need to be reporting to MIPS. So I would check with your ACO administrator or whomever handles the participation list to make sure that all PINs and NPIs that should be included are included. Any other questions? We'll be holding these calls not bi-weekly, but roughly bi-weekly, twice a month. So we hope to have additional updates for you. Obviously, today was special because the proposed rule came out last night, so we were eager to get that information to you. If you have any questions related to that, please let us know. As I mentioned, comment on the proposed rule is open until August 18th, so you have about 2 months. I highly recommend if there's anything in there that you want to have adjustments made on or recommendations for, or you just absolutely think should be removed, please make sure that you submit those comments directly to CMS. They do listen. When the final rule for QPP was made available back in October 2016, there were almost 4,000 comments. So there's definitely a need for people to comment and make their voice heard. So that's available for you. Make sure you utilize it. Any questions that you might have that come up, please let us know. We're happy to help you with those. Again, there's some exciting changes, I think, for clinicians maybe that are in the smaller rural practices that need a little extra help in this next year, but it's an exciting time.
Thank you, Leela. It's Olivia. I'm going to stop recording now, unless there's any additional questions or anything else you'd like to add.
I don't think so. I think that's fine. Thank you all. I guess we'll cut it short at half an hour. I wasn't sure if anyone had a lot of questions, and if you have any specific that you want, like I said, just feel free to shoot us an email or submit a question via our website.